Assalamualaikum and good morning, everyone. Welcome to Grand Clinical Pathological Conference. Today our host will be Upper GI and Metabolic Surgery Unit, Department of Surgery. Welcome to our honourable speech, Prof. Associated Prof. Dato Ritza Kosai, Prof. Norlaila Mustafa, Senior Consultant as an endocrinologist, Mr. Lu, Bariatric Surgeon, and as well as Madam Michelle Tan Hwee Peng, Head of Pharmacy Department, as well as Dr. Nasiha binti Abu, the pathologist. So, without further ado, I would like to invite Prof. Nick to moderate, act as a moderator in our Grand Clinical Pathological Conference today. Please welcome.
So ni, tekan ni untuk I want that picture. Mana? Okay. Assalamualaikum warahmatullahi wabarakatuh, and good morning everyone. So welcome to the CPC this morning. So one's wonder what is upper GI unit presenting on a medication rather than something surgical. But nevertheless, you can see one of the title in our unit is metabolic surgery. So metabolic surgery primarily aim to treat diabetes and its metabolic associated disease like hypercholesterolemia, hypertension, fatty liver, and etc. But it's coming much more into light lately of the association between a general surgical problem and the drug, which is pretty rife nowadays, which is used to treat obesity. The history of this drug primarily, which is generic form of GLP-1, glucagon-like peptide, is primarily initially used for diabetes, but on a higher dose, it was found to be very useful in making people lose a lot of weight. But then the direct and indirect consequence of weight loss has, of course, its consequence. And one of them, lately, we have noticed that a patient that was admitted under our unit, so we cover general surgical cases when we're on call. So we had a few cases where they got admitted with abdominal pain. And these patients were either mildly obese or some are pretty obese. But I'm not surprised. You know, those who come in our door nowadays, 7 out of 10 will be either obese or overweight. If you base on the Asian criteria of obesity, starting with a BMI of 27.5. So if you look at the National Health Mobility Survey 2023, the incidence of obesity in this country has increased nearly 10% from a decade ago until now, which is about 53%. But that's based on the WHO criteria of BMI 30 and above. But if you reduce the goalpost down to 27, then it's around 70 to 72% of either our population is obese or overweight. So to find a very slim person in this country now is a very rare breed. Okay? So nevertheless, going back, and why I actually put this picture is because, you know, living in this current era, we are living in exciting times in comparison to like a decade ago or 2 decades ago, because science has advanced very fast. And more new countries are developing new technologies. And one of the important countries nowadays is China. Okay, so, you know, I think the presence of China has made more and more technology in terms of armament to combat disease, but also making it become more competitive. So the good news about competition is it making things much more cost-effective and more affordable. Plus the emergence of countries like India as well. And we're talking about these drug patency will eventually perish in due course. And one of the drug is GLP-1, which has become more generic. And India has come up with a much more affordable medication. And it's as affordable as 10% of its cost compared to the, for example, Wegovy or Mounjaros. But the reason why I'm putting this slide is because more and more new drugs are emerging. And of course, we have oral drugs and subcutaneous medication. And the present one in Malaysia is for specifically obesity. I'm not talking about diabetes. For obesity is Wegovy, which is the extension of, which is semaglutide, which is an extension of Ozempic, because Ozempic stops at 1 milligram and Wegovy is 1.7 and 2.4. And of course, we have the Mounjaros, and the state is called Zepbound. But Wegovy also is coming up with Wegovy pills, 25 and 50 milligrams, and FDA has just approved the latest oral drug, GLP-1, which is Fundeo, which is orforglipron. So, and as you can see, there are more and more new drugs, and its efficacy is astounding. And it can make people lose up to 20, 25%, and I wouldn't be surprised, 30%. But, of course, the downside is the side effects, and it's still very expensive to the general public. So that's why it's not in our HUKM formulary, but they have the options to get it from a UKMSC pharmacy. But I'll give you an example. One pen is 1K. But it's really good for if you're going to lose like 5 to 10% of your total body weight, it's perfect because you only need for 1 or 2 or 3 months. So it's pretty affordable. But if you need to lose like 50 kilos, then I think bariatric surgery would still be a long-term cost effectiveness. So without further ado, the reason why I stand here is to introduce our next speaker to talk about an interesting case. Not just one, but we had several patients come in on GLP-1, presenting with abdominal pain. And as you can see, the drug safety information did mention one of the rare but adverse side effect will be inflammation of the pancreas. So does it directly or indirectly cause? So we are yet to know until my next speaker will highlight and enlighten us. Okay? So I'll call the next speaker to come in.
Okay, thank you, Prof. Nick, for the welcoming speech. So here I would like to present a case regarding GLP-1 medications. So a brief history about the patient. There's a 45-year-old woman presented to us with a 2 days history of epigastric pain. So this is chief complaint for the patient. Next, about the further history, the pain actually was started 2 days prior to admission, located more at the epigastric region and radiates to the back. It was constant, severe in intensity, and it's also associated with nausea and multiple episodes of vomiting. So next, the further history when we took from the patient, patient otherwise no fever, not appear jaundice, no change in bowel habits, and as well as no prior similar episodes. Background for the patient is a patient who is obese, 34, BMI is 34, and she was started on pharmacological weight loss therapy about 4 months duration. And patients experienced significant weight loss, is around 12 kilos. So since majority of us is undergrad students, so I would like to ask what else we want to know from the history of the patient. May I have some volunteer here? Any volunteers from the floor? Especially the undergrad students? Tak ada? Okay, may I have the first one on the left side? The first row in front, at the middle. Yes, please. Just a volunteer. Just give what your thought based on the history and presenting complaint. Yes.
Any nausea or vomiting?
Mentioned just now. Before that, may I know your name?
My name is Najwa.
Najwa. Okay. What else? What else you want to know?
Any radiation of the pain?
Yes, it's radiated. Mentioned in the history.
You mentioned
Radiated
just
to the back.
epigastric region.
Yeah.
Or radiated to the back.
This another clues. I mean, what we got from the patient. So what else you want to know about? Any other volunteers? Maybe the one at the back. The first row as well. The blue row. Can please help her? Yeah. Yes. Come. Faster.
Since patient have some vomiting, maybe you can ask what's the content of the vomiting.
Sorry. Louder.
Maybe the patient have vomiting, multiple episodes of vomiting.
Okay.
So maybe you can ask her to quantify the vomit and the content of it and the relation with meals.
Okay. Correct. Thank you. So here come the interesting part about this history, where we can see from the background of patient, we highlight there the patient is obese with BMI of 34. So we need to know more about the what he have took about the pharmacological weight loss. So on patient was on weekly injectable GLP-1 receptor agonist, which is semaglutide, and we have to know also patient got history of ultrasound abdomen 6 months prior to the abdominal pain, where the result shows a gallbladder polyp with presence of sludge. Didn't mention about the stones, and patient is non-alcoholic, non-smoker, and again no history of gallstone or pancreatitis before. So no previous abdominal surgery and no previous history of pancreatitis, no family history of pancreatitis as well. Okay, with this additional information, what are the next thinking in our mind? Can I have a first red flow? What do you think of the diagnosis now at the moment? Any other volunteers? Tak ada. Okay, so it's okay. So I will proceed with the our leading diagnosis now. Before few differential we should come out with the based on the history and physical examination. So the examination I tambah sikit lagi. Physical examination, patient is febrile with pulse rate is around 110 beat per minute. Blood pressure is within a normal range, 130/78. Abdominal examination, there's a epigastric tenderness, guarding, otherwise no palpable mass, and patient is not jaundice. Initial investigation shows white side is on high side, which is 14. CRP is high, 22, and the serum amylase is under 1,820. Otherwise, liver function mildly elevated ALT, AST, and the total bilirubin was normal. Okay, so yeah, may I have this man, single man at the blue? Yeah, can I have? What is your provisional diagnosis?
Okay, so hello, my name is Levendra. I'm from 50 Medicine. So my provisional diagnosis would be acute pancreatitis, evidenced by the serum amylase being 3 times higher than the upper limit. More than that.
Based on amylase alone, or do you have any other? And what are you thinking of the etiology here for this patient? Since we already ruled out alcoholic, smoking, and all those things.
Could it be infection related?
Do you need, possible, but do you think, do you need any additional information or any additional adjunct to support your diagnosis?
serum lipase be needed in this case?
It's okay, can, but the serum amylase already high.
Then can proceed with any radiological investigations.
Which is?
CT scan.
Yeah, can. So first of all, we proceed with the ultrasound endowment first. We know that the patient is obese with BMI 34, so most likely the ultrasound is not giving so much clues. But in this case, we can see there's a multiple small gallstones. This current imaging, multiple small gallstones, no gallbladder wall thickening, no pericholecystic fluid, and the CVD is not dilated. Hence, we proceed with the CT abdomen. So the CT shows features consistent with acute interstitial pancreatitis, otherwise no necrosis and no collection. So we can see here the cut section of the CT scan of the patient. You can see there's a bulkiness of the pancreas, and with this one there's the imaging. The video showing for this patient. Since we suspect pancreatitis in this patient, so we will focus more on the abdomen. We look at the pancreas appearance. Okay, as we can see here, there's a bulkiness of the pancreas along this way. Otherwise, no peripancreatic collection, no signs of necrosis from the CT. Okay, everybody can see? All right, so go through. There's a small stones there from the gallbladder. Otherwise, other organs appear to be normal. As we can see here, there's quite obese, thick fat for this patient. Okay. All right. So, okay, what's next? What is the final diagnosis and what is the pathophysiology? Maybe one at the back. First row at the back, the blue tudung. Yeah, yes. Please, help us. Come.
My final diagnosis will be acute pancreatitis, as evident by the bulkiness of the pancreas from CT scan.
Okay, okay. That's all? Any other words you want to add?
No.
No, okay. Thank you so much. So this is the final diagnosis. Since I don't have much time, so this is the final diagnosis for this patient. We come up with this diagnosis because patient having gallstone pancreatitis as evidence from the ultrasound, likely precipitated by rapid weight loss associated with GLP-1 receptor agonist therapy, since the patient have took that medication for the past 4 months. Okay, so here come the clinical pathological correlation. I think I will touch a bit surface about the clinical pathological, because my friends will add more in detail about the pathology. So the patient having a rapid weight loss where it's increased cholesterol supersaturation of bile, and then from there another pathology was a gallstone formation, lead to migration into the biliary tree and lead to transient obstruction at the ampulla, where the pancreatic enzyme activation lead to acute pancreatitis, inflammation of the pancreas. And the pathophysiology here, we can see another mechanism how GLP-1 can cause pancreatitis. So we can see the few mechanisms. Number one is direct pancreatic exocrine stimulation, where it's GLP-1 receptor mediated. Secondly, is increased pancreatic enzyme synthesis. There is an overload hypothesis. And gallstone mediated pathway, where we can see, like example for this case, this patient took semaglutide, so caused rapid weight loss. It's a loss around 12 kilos. So this causing increased biliary cholesterol saturation and reduced gallbladder motility, lead to cholecystitis. As we all know, so cholecystitis is a major cause of pancreatitis, gallstone pancreatitis. So the patient lead to secondary acute pancreatitis. Another mechanism patient is this physiology can got altered pancreatic ductal secretion dynamics, where affect bicarbonate secretion and ductal fluid dynamics. So lead to viscous secretion or reduce the flow. Predisposition to the ductal obstruction lead to pancreatitis. And another theory is immune or inflammatory modulation. GLP-1 analogs have systemic effects on cytokines and inflammatory pathway. So this especially in a susceptible individuals where idiosyncratic inflammatory pancreatitis can occur, lead to pancreatitis. Okay, so I think the management mainly because of for the pancreatitis, fluid resuscitation, analgesia, nil by mouth, we need to monitor closely for the patient and to look for the change for the severity of the pancreatitis. And we have to take early enteral feeding when patient is tolerated, and antibiotics if only infection suspected. Like in this case, we started antibiotic because of the parameters is shows infection. So definitive management, once a patient resolved from pancreatitis, we lead to interval laparoscopic cholecystectomy, and we need to consider the timing after resolution of pancreatitis and to evaluate the ongoing GLP therapy. So why this case is important? So the question here is GLP-1 therapy contributing to gallstone disease? So we already know the answer is yes. And what are the implications in modern obesity management? So a brief about the GLP-1 receptor agonist is actually mimic natural hormone GLP-1 in our body, where it reduce appetite, delay gastric emptying, and promote weight loss. So its effects was lead to rapid fat mobilization, increased biliary cholesterol saturation, as well as reduced gallbladder motility. And the recent evidence we got where semaglutide can significantly reduce weight as evidence from the STEP trials. Later we can see where the STEP trials is and then tirzepatide also may lead up to 20% total body weight loss. So have to look also at the adverse event, increased risk of gallstones and increased risk of pancreatitis. So this is drugs information for semaglutide. As we can see here, there are few adverse event, adverse reaction, but I would like to highlight these few things, which is a cholelithiasis, and as well as increased lipase and increased amylase reading in the body. So that's why this can lead to pancreatitis. So there's one I would like to share one study there where I mentioned about receptor agonist initiation and risk of acute pancreatitis and pancreatic cancer. This is a real world comparative study. So actually this study to examine the association of GLP-1 receptor agonist with the risk of acute pancreatitis and pancreatic cancer. So they use dipeptidyl peptidase 4 inhibitor, DPP-41, as an active comparator to reduce the bias. And result shows acute pancreatitis was diagnosed in 0.24% patient taking a DPP-41 user, and as well as 0.31% with a GLP-1 receptor agonist user. While pancreatic cancer, 0.17% developed in patient taking DPP-41 inhibitor, and also 0.24% in GLP-1 user. Okay. So I think a bit more about this GLP-1 advantage is a non-invasive. Otherwise, it's effective 10 to 20% total weight loss and requires long-term. So the surgical therapy for weight loss is a bariatric surgery. Okay, as we usually done here, it is a more durable for weight loss, in a higher metabolic remission, and it is invasive but a definitive treatment for obesity. So this drug also have a local implication, which is increased GLP-1 in Malaysia. The cost is high, around 900,200 per month, and there is no insurance coverage. Patients have to buy themselves, and there's a potential increase in gallstone disease and as well as a surgical referrals. So need for integrated obesity care pathway. So the key learning point here, I would like to highlight, acute pancreatitis in obese patient requires evaluation for gallstone etiology, and rapid weight loss, including pharmacological therapy, increases risk of gallstone formation. And GLP-1 receptor agonists are effective, but require careful monitoring for complications and the side effect, and as well as multidisciplinary approach is essential in modern obesity management. So bariatric surgery remains a key definitive option in selected patients. I think that's all from my presentation. If there are any questions, maybe at the end of the event today. Thank you. I would like to invite Prof for the next talk.
Assalamualaikum and good morning. Thank you to Surgical Department for inviting me to give the talk during CPC. So now I'm going to talk about the role of GLP receptor agonist or GLP-1RA in metabolic syndrome. But first, let me share with you what we have now in Malaysia. So again, based on 2023 NHMS survey, we know very well that over 500,000 population in Malaysia, adult more than more than 18 years old have 4 non-communicable disease. So you can see diabetes, hypertension, high cholesterol and obesity. And what actually even more worrying is that our nations are getting fatter and fatter, and within about 20 years, between 2011 to 2023, the increment in obesity is about 10% every time the survey is being done. And of that, about 2.3 million adults had at least 3 in 1 comorbidities, either diabetes, hypertension, high cholesterol, or diabetes, high cholesterol, obesity, and the list goes on. And what contributed to this is because 1 in 3 adults in Malaysia are not physically active. So you must ask yourself whether you are physically active or not. And 1 in 2 leading a sedentary lifestyle. And this is also contributed by lack of sleep. You know, everybody's busy, everybody's with their gadget at night and so on. So lack of sleep also contribute to obesity and metabolic syndrome. So how do you then diagnose metabolic syndrome? What you need is 3 out of 5 criteria. The criteria, as I showed you here, is central obesity, high TG, low HDL, elevated blood pressure, and elevated fasting blood pressure, or they are taking medication for those conditions. Now, for central obesity, we agree that for Asian, the length is actually much shorter than Caucasian, about 90 centimeter, and women 80 centimeter. So you got to go back and measure your waist circumference as well. And when metabolic syndrome was introduced back in 1980s, there's a lot of definition of how people actually diagnose metabolic syndrome. But until 2009, about 4 years after the IDF definition of metabolic syndrome, there's joint interim statement from different organization, IDF, ADA, American Heart Association, and so on. We agree to unify the definition to the most current one, as I showed you in the picture here. So really, if you look at the diagnosis of metabolic syndrome, it's actually a cluster of biochemical or physiological abnormality, as you can see. And in Malaysia, there's 2 big studies looking at metabolic syndrome by the UITN group from 2007 until 2011. They're looking at more than 7,000 subjects in rural and urban population. So the prevalence was 43.4%. And we, with other institutions, did a metabolic syndrome study from 2007 until 2011, different population as compared to ITM. Again, the metabolic syndrome was also about the same, 42.5%, and there's not much difference between urban and rural population. So everybody's getting fatter and have a lot of comorbidities. So this slide just to show you a flow chart of the end staging of metabolic syndrome. So you can see metabolic syndrome is really a progressive abnormality. So if you look at stage AU, the future healthcare professionals and the current healthcare professionals, doctors, you have to identify, and for whatever reason that your patient comes to see you in your clinic, you have to assess whether the patient are overweight, whether they have susceptibility to develop metabolic syndrome as conferred by ethnicity. In Malaysia, being Indian, they have high risk of metabolic syndrome based on both studies, whether your patient is physically active or not, and whether the parents have metabolic syndrome. So the therapy then is not GLP-1 receptor agonist. So you have to talk about obesity prevention, nutrition and activity. And similarly, stage B, they have not yet developed metabolic syndrome, but it's progressing. They have 1 or 2 criteria. Again, you have to talk about risk factor modification, or if the abnormality warrant any medical therapy, then you may treat the patient. Stage T, they already had or developed metabolic syndrome, and by the time that they become stage D, they already had all these complications: CVD, CKD, OSA, PCOS, muffle or fatty liver, and other mechanical issue like spine and also knee OA and so on. So by then you have to also start treating based on the disease that they have. Now, a lot of studies have used GLP-1 receptor agonists in a lot of end organ damage associated with metabolic syndrome, or I can say that specific disease that the patient has. So what is GLP-1 receptor agonist really for the benefit of medical students and the young doctors? Is actually a class of medications that mimic the GLP hormone or incretin hormones. Where is this GLP hormone being secreted? It's being secreted from the L cells of in the ileum. So when you eat, your GLP will be secreted. So how GLP-1 works? It stimulates insulin production. That's why it is being used as anti-diabetic medication. It reduces glucagon release, therefore your sugar will be low. And at the same time, it increases satiety, and that's the reason for obesity medication, what is being used. So this just to illustrate what happened with GLP-1 hormone that release as you eat your food. And I mentioned to you that GLP-1 is actually an incretin. The work on incretin has been done about 100 years ago, almost 100 years ago, back in 1930s. It is actually insulinotropic gut hormones because it stimulates insulin production. And the identification of GLP was first talked about in 1983, and then followed by 1987, people start to isolate, and the production of GLP-1 receptor agonist has really started in the lab. So what is the role of incretins in glucose homeostasis? So this is to share with you a little bit more detail than what I mentioned about GLP-1 hormone. So when you eat your food, okay, as your feed go through the gut, and it will then stimulate your gut to produce GIP. GIP is also incretin hormone. GIP is gastric inhibitory polypeptide. It has a role in obesity, treating obesity as well. So that's why the GLP, GIP, the tirzepatide or Mounjaro is combination of both. So the incretins, or both active GLP and GIP, will be released. GLP from the ileum and GIP from the proximal part of the gut. And with that, the insulin will be stimulated both by the GLP, GIP, and it then will cause increased glucose uptake by the muscle. Therefore, your glucose level will reduce. And when someone, at the same time, the GLP will also stimulate the alpha cell to cause reduction in glucagon. You know what glucagon does? It will cause gluconeogenesis. So in that, it will inhibit glucose production by the liver or inhibit gluconeogenesis and lead to decrease in glucose level. So what really happen in your body and our body, there is a DPP4 enzyme that will inactivate the GLP and GIP in your body, and therefore it's short-lived. So it will last for about 2-3 minutes and that's it. Okay. So therefore, with evidence that GLP-1 hormone has a broad pharmacological potential. Why? Because there's a lot of receptor, GLP-1 receptor in your brain, in the heart, in the kidney, in the endometrium, in the vessels, of course in the stomach, in the pancreas, stimulate alpha and beta cell. So a lot of fundamental research has been done and showed there's metabolic effect of GLP-1, there's glucose-dependent stimulation of insulin secretion, decreased gastric emptying, inhibit food intake, increased natriuresis and diuresis, and modulation of beta cell proliferation. At the same time, it may be cardioprotective because it reduce inflammation and apoptosis, implication for learning and memory. Therefore, it may good for Alzheimer's patient, reward by behavior in terms of food intake, the satiety, and also the hunger feeling. And because of that, biochemically modified, the GLP-1 receptor agonists are successful in clinical use. However, because of the GLP-1 is a hormone. When you talk about hormone, it's amino acid, it's peptide. So development takes a long time. Only in 1987 to in early 2000, about 20 years ago, the GLP-1 receptor agonist has started to develop commercially. And as you can see, you know, there's liraglutide, daily dose, and then followed by semaglutide, weekly dosing, and weight loss after that. 2021, higher dose semaglutide 2.4. Tirzepatide is combination of GLP, GIP, approved for both obesity and also diabetes. And of course, there's a lot of development of new molecules. The orforglipron is actually a small molecule. It's not a typical GLP-1 because how you differentiate from ribelsus. You don't the way patient take it is not very tedious. You don't have to take with empty stomach or with a little water. So you know, these are the development with regards to GLP-1. So most GLP-1 agonists are based on proteins or peptides, as I mentioned earlier, and that's why it is administered via injection. Is more stable. Although in the past, a lot of studies have tried to produce GLP-1 sublingual inhalation or even implantable device, ITCA 650, and also recently ribelsus with the SNAC technology that's being used in the market. So how does GLP-1 cause weight loss really? So what you want to share with you here, as you eat, when you eat, then what happens is there'll be an afferent neuronal signal will stimulate your hypothalamus. What you have in hypothalamus in the arcuate nucleus is the POMC or pro-opiomelanocortin, which is a orexogenic neurons. Orexogenic means it's appetite suppressant. So it is being stimulated by the receptor, by the presence of GLP-1 receptor, and at the same time will inhibit NPY and AGOT-related peptide, and therefore there will be reduction in food intake by the patient. So at the same time, GLP-1 also cause delayed gastric emptying. Therefore, your patient will feel full most of the time, and therefore they will not eat so much. Okay, so that's the basis behind it. Okay, I'm coming to the end now. Of course, there's a lot of receptors of GLP-1 in all the organs that I mentioned earlier, and really it has potential in cardiovascular prevention, reduce all the major cardiovascular events such as heart attack and stroke. It was being shown with the Pioneer study. Kidney disease protection, reduce risk of kidney failure and decline of renal disease progression in those with type 2 diabetes. In flow study, it has been used in liver steatosis, inflammation and fibrosis, and as I mentioned earlier, in neurodegenerative disease because of reduction in inflammation and the presence of receptor in this region. But really, if you talk about how it reduces the cardiovascular disease, kidney disease, liver disease, because it's all associated with fat and insulin resistance, and that's how it works as well. And with that, I thank you. The next speaker will talk more about the side effects of GLP-1. Of course, our Madam Pharmacist, Michelle.
Thank you.
Okay, thank you, Prof. I will continue from the pharmacist point of view. So I imagine that in my line of work, usually we will get calls from the doctors asking, is this drug safe to use? What are the common side effects? If my patient has pancreatitis before, can I restart the GLP or not? So I'm looking at it from that point of view. We'll be running through literature and what the latest evidence has to say about pancreatitis risk with GLP use. And as Prof mentioned just now, this is the simplified mechanism of action, but generally just to show you, most of the GLP-1 that we have right now in Malaysia are this second generation, semaglutide, liraglutide, dulaglutide, and the new kid on the block, tirzepatide, Mounjaro. Common side effects, just to highlight to you, the common ones, because of its mechanism of action at the GI tract, the common side effects will be nausea and vomiting. And also an alert for you, it could be a common side effect, but it could also can be early signs of the pancreatitic symptoms if it is accompanied by severe abdominal pain as well. So you need to watch for all this, okay? Early years, when this drug was launched, everybody was very excited because of all the great metabolic effects it has, and then now with a lot of cardiovascular outcome trials. So when everyone was very excited about the drug, there was increase in the drug use, right? But when there's increase in drug use, there was also increase in early signals from case reports that there were pancreatitis side effects, and there were also fatal and serious side effects with regards to GLP use. So then it warranted warnings and precaution. You know, when you buy any drug, there's actually warning and precautions inside the box. Many of our patients, including I think many of you, when you buy a drug, get a drug, you throw away the paper inside the box, right? Actually, everything inside the product insert is very important because they have warnings and precautions which are collected from clinical trials and also post-marketing surveillance. So inside the product insert, all regulatories around the world was asked to update this part, warnings and precaution. Acute pancreatitis has been observed in patients treated with GLP-1, including semaglutide. This one I just pull out from semaglutide product insert. So it already mentioned here, acute pancreatitis, including fatal and non-fatal hemorrhagic and necrotizing pancreatitis, has been observed. Okay, so when you see like Dr. Rahim's case just now, this is the warning has already been given here, but was the drug started appropriately in this patient just now? We are not sure. Was the warning heeded by the previous physician who started this drug? We are not sure, okay? So this one is just to highlight regarding the warning that has already been given. Many years ago, remember the drug was launched about 2007, but when the spike of the drug, when everybody started to use, then people started to see also a spike in the side effects. And pancreatitis was one of the key things that they noticed. European Medicines Agency already started to investigate in 2013. 2013 until now, how many years was that? It's about more than 10 years already. But how come January 2026 this year, there was a recent update again by Drug Safety, by Medicines and Healthcare Product Regulatory Agency, saying that they would like to strengthen the warning on acute pancreatitis, including necrotizing and fatal cases. Okay, why did this happen? Is it the drug is not too safe? They have some extra warnings over the 10 years. So let's just look at the literature. When we look at pancreatitis risk across drug classes in type 2 diabetes treatment, generally, these are all the classes, right? But we'll be focusing on GLP. So in terms of pancreatitis risk, this one has extra warning at this moment. What happened is, previously it was a concern, but as people use the drug, people are very curious also to test the drug in patients who had no risk of pancreatitis, and they also challenge to try whether it's safe to use GLP in patients with history of pancreatitis. So let's look at the RCTs that was done. If you notice, most RCTs are controlled setting, correct? So by the time the alert already came out in 2013, all the landmark trials of this GLP had already excluded patients with history of pancreatitis. So now then, do we have data whether GLP is safe in this group of patients? Not really, because they were already excluded from the start. So then there were people who were very curious. Okay, if GLP has this side effect warning, maybe I should look at the group of patients without the comorbidities. So then they look at the more large studies and meta-analysis. They tried to look at patients without this comorbidity, and they tried to see whether GLP itself was the culprit in increasing the pancreatitis risk or not. And the studies found that there was mixed data. A propensity scored matched cohort study of adults with type 2 diabetes, free of the comorbidities like gallstone and alcoholic use, showed that those on GLP-1 had similar or even lower pancreatitis risk compared with non-users at 1 and 3 years. And then as you prolong the use, they found that, how come the GLP had a lower lifetime risk? So probably it's the protective mechanism where when you use the GLP, you also control the diabetes, you also control obesity and all the metabolic problems, right? So then people became more curious that they tried to introduce GLP in patients with prior pancreatitis risk. Earlier on, everyone was scared. Maybe we should just avoid. But since the data shows like some safety signals, let's try. So there's this small study which they tried because they are very curious what happens in a real-world patient who already had pancreatitis. So this study reported incidence of acute pancreatitis with GLP use in those with prior history of pancreatitis. So it showed that the risk of recurrence was about 10%, and it was likely no greater than what was observed in the general population, and that more than half of the episodes of recurrent pancreatitis were due to other risk factors. So they're saying that probably it's not the GLP, but it's maybe the cholelithiasis, alcoholism, and other things. So they're saying here that GLP seems quite safe. And then more people became curious and they wanted to do more meta-analysis, looking at 31 randomized controlled trial they had about 40,000 patients, and they zoomed into semaglutide and tirzepatide safety. So it showed that when compared to placebo, macam safe pula in this study, like no pancreatitis risk. And they continued. So there are so many meta-analyses now looking at the safety of GLP in patients with or without pancreatitis. And this was a double of the previous study, 62 RCTs. But how come this was different results compared to the results just now? Just now showed like it was not associated with increased risk of acute pancreatitis, but this study analysis suggests a potential risk of increased pancreatitis, but it was weakened after they analyzed, they minus off, they stratified with the background use of medications. So reading the data can make you confused, even though meta-analysis is like level 1 evidence. But you can see that it's a mixed review. So that's why here I would like to promote, not yet promotion. Okay, this one, almost the last slide. The reason I pulled this out because this is from Gastroenterology Journal, because today's topic is by upper GI, right? So here there's one paper that says GLP-1 receptor use does not increase the risk of acute pancreatitis and is associated with lower complications in patients of type 2. Again, it's like promoting the use of GLP, but please always take a look at the exclusion criteria. These kind of patients with high risk already excluded. Okay. And here comes the promotion too, where I would like to encourage everybody. It is so important. You have case reports, you have RCTs. RCTs are always short term, 2 years, 3 years. And then you have meta-analysis looking at all the data. But don't forget, post-marketing surveillance reported by you and me, very important. These data are not captured in studies. It's real world, it's the real patients. So when your patients get any side effects, and then when you report, it contributes to the real world evidence. So the whole world is now collecting data for incidence of any kind of side effects with this drug use. The more data we have, the more we can come to something safer. Okay, so pharmacovigilance analysis from real world evidence, this one from UK, this one from US. I called our regulatory, we only have 2 reports so far. Pancreatitis with semaglutide use, because also we use less semaglutide compared to other countries. So in UK, 2007 to 2025, about 1,000 plus. But this is the one that regulatories are afraid of because they are fatal outcomes. Even though it seems rare, but it's severe. Okay, so you still have to be careful. And this is from US, 6,000 plus reports of acute pancreatitis, and 98% deemed serious, 40% of them were hospitalized. If you look at most of the pharmacovigilance data, like what Prof, I think Dr. Rahim mentioned, when you increase the dose, right, you actually increase the risk of the pancreatitis as well because of the high rapid loss. So those 25% of the patients experience events within 3 months after they increase the dose. Median onset, Dr. Rahim's one, I can't remember how many weeks or how many months, but median onset reported here was about 3 months after starting. Typical symptoms that the patients complained was severe epigastric abdominal pain with nausea and vomiting. Okay, so this is from the post-marketing evidence. So what we know is that we do not have a proper RCT because RCT already excluded most patients with history of pancreatitis. So we know that we do not have enough data. And observational data shows slight risk, but mixed results in meta-analysis. What we don't know is whether GLP is truly safe or not, because in so many studies, there's so many other confounding factors. As you saw from the meta-analysis itself, it's confusing enough, right? One moment okay, one moment not okay. When you look at their exclusion criteria, also everybody does it in different groups of patients. So lower recurrence rate from what you read in the meta-analysis does not prove that the drug has a protective effect, because you have to look at the excluded subgroups. Okay, finishing here. Latest guidelines, if you can see, there's always a key language where they use. They say, consider alternatives. They warn about the risk. They said, use carefully. So is it an absolute contraindication? It's not exactly an absolute contraindication, but it's a caution. And when it's a caution, it's our role. I mean, it's doctor's role and the pharmacist's role. Pharmacist's role, education. Doctor's role, education and proper screening to assess the risk and benefit of the drug before you start. Because now the magical word around, you can see on TikTok, and all your friends and families will be asking you, this drug very good, right? I want to buy. What do you think of it? It's so easily available. So it's us to educate them. So these are the January 2026 drug safety update from UK Regulatory Board. The clinical action that we need to do to remind ourselves is that we need to remind them to be alert. If there are severe persistent abdominal pain radiating to the back, they need to inform the side effects if any of your patient has these symptoms, okay? And it's also high vigilance for providers, like what Dr. Rahim's case just now. Remember to ask about the medication history if they are on any GLP. And if the patient is on the drug, we'll need to stop immediately if they come in with the pancreatitis. So in summary, safety messaging should therefore emphasize appropriate supervision, nutritional guidance, recognition of biliary symptoms, and assessment for gallstone etiology, rather than saying that I confirm this drug is the one that's causing the pancreatitis risk. Okay, thank you. Yeah, inviting up pathologists.
Okay. Assalamualaikum. I'm Dr. Nasiha from Patology Department, particularly the Histopathology Unit. So I'll be talking on the clinical pathological effect of GLP-1. So my focus is mainly on the pancreas. So before we go into the pathological changes, let's just recap the normal histology and function of our pancreas. So basically, pancreas is function 99% has an exocrine function. The exocrine function is mainly composed of acinar cells, and ducts. These acinar cells are those small, like darker color glands here, and the ducts are here where it drains all the pancreatic enzymes. So acinar cells contains your pancreatic juice, which is composed of your bicarbonate and your pancreatic enzymes such as lipases, amylases, and trypsinogen. So what about the endocrine function of the pancreas? It is comprises only about 1% of the normal pancreas, what we call islets of Langerhans. Islets means small islands, actually. So you can see here the cells are arranged in small islands amid all these acinar cells. So the islets of Langerhans consist of several cells producing various hormones. For example, your beta cells for insulin, your alpha cell for glucagon, and your delta cells for somatostatin. So if you were paying attention from the previous lecture, you know that GLP-1 actually mainly acts on your endocrine function. So this is another high magnification of your exocrine part of your pancreas consisting of acini and also your duct. Your acini is a bit intense in pink color because it contains a lot of enzymes. So when you talk about pancreatitis, actually you are talking about the exocrine part of the pancreas, so information of the exocrine part of the pancreas. So as I mentioned before, that GLP-1 mainly acts on your endocrine part of the pancreas. So how would you affect the exocrine part of the pancreas? So actually study shows that GLP-1 receptor, even though it is primarily expressed in your pancreatic islands, it is also present within your duct and acina, which is your exocrine part of your pancreas. So what are the mechanism of GLP-1 causing pancreatitis and other its clinical pathological effects. So as mentioned repeatedly before, biliary stasis and gall formation is one of the main cause, where the GLP-1 can slow down your gallbladder motility, reduce its movement, and can lead to formation of gallstones, which then can block your bile and cause acute pancreatitis. So female over 40, overweight, or experience a rapid weight loss are more likely to develop these gallstones. So what about the direct pathological effect? So there's an emergent mechanism by which there is pancreatic duct hyperplasia. When we say hyperplasia, means increase in number. So when there is pancreatic duct hyperplasia in response to GLP-1 therapy, they will cause increased risk of duct obstruction. Why? I will show a picture later. So this then will cause backflow effect and activation of pancreatic enzyme and leading to pancreatitis. So this is an example of a histomorphological changes studies in rat with control, and the subject was given twice weekly treatment for 13 weeks. So this is the ducts that I've mentioned before, surrounded by acini containing your pancreatic enzyme. So after treatment for 13 weeks, you can see there is increase in number of these ducts, which we call hyperplasia. And if you notice, the lumen of these newly formed ducts are actually smaller, which this leads to increase in risk of obstruction. There's another study also done in rats where you can see evidence of increased number of these ducts after 12 weeks of treatment. So other causes are acini cells destruction. So the historical study in rat pancreas reveals that there were abnormal acini morphology, and there is increase in frequency of these acini cells, leading to systemic release of your pancreatic enzymes. So these are the acini cells that I've mentioned before. If you notice, there is like what we call pycnotic nuclei. Pycnotic nuclei here is a process of cell death where the cell's nuclei shrinks and also the cytoplasm becomes more paler, meaning it is undergoing cell death. This is a more severe picture showing atrophic and destruction of its acini cells. So other changes in pancreas includes acini cell hypertrophy, which is possibly due to the increase in protein synthesis within the cells. There is overall increase in pancreatic mass. And what about the endocrine changes? It is noted to have increase in beta cell mass. This is primarily due to hyperplasia rather than hypertrophy. We have alpha cell hyperplasia and also enlarged islet size of the pancreas. So going to areas of controversy, what about dysplasia and neuroendocrine tumor? So these are controversial and debatable. So if you can recall what Dr. Rahim mentioned before, there are studies showing there is a risk of causing pancreatic cancer. So this study, it examined 13 organ donors that received this therapy versus a 14 diabetic patient without the therapy. And he observed that there is an increase of pancreatic intraepithelial neoplasia, what we histopathologists always call PANIN. So pancreatic intraepithelial neoplasia is actually a pre-malignant lesion in diabetic that he found in diabetic part 1 patient, and then compared to those who are not receiving the therapy. Additionally, a neuroendocrine tumor was also identified in one of the pancreas from the incretin treated group. So what is PANIN? Pancreatic intraepithelial neoplasia. So recall the ducts before. So when PANIN occurs, the ducts become abnormal, where it shows some papillary tufting over here. And if you can see clearer, that the nucleus, rather than it sits basally, it starts to proliferate upwards. There's loss of polarity, there's hypochromasia, and there's a bit of irregular nucleus here. So these are PANIN, which are the pre-malignant lesion. So what are the expert opinion on this? So actually preclinical animal study primarily shows mainly benign structural changes, such as I mentioned before, duct gland hyperplasia, increase in pancreatic weight, beta cell mass. And crucially, these animal models showed no risk of neoplasia. So clinical trial data and post-marketing reports also show limited evidence of increased pancreatic risk. Therefore, the rarity of this pancreatic cancer necessitates a larger and long-term studies for conclusive evidence. And the current data do not support any new safety signal, but highlight, as I re-emphasize what Puan Michelle mentioned before, the need to continue monitoring and research regarding this entity. Thank you.
Okay, thank you so much for the honorable speakers, Prof. Ni, Prof. Norlaila, Puan Michelle, and also Dr. Nasiha. So I think we are going to the end of the session today. Before we end, I would like to ask the floor, is there any questions to ask specifically to our speakers today? Before we're going to ask you a few questions before we leave. Okay, open to the floor.
Assalamualaikum. Good morning. Thank you for the presentation. Semua dah nak keluar dah. Can I ask Prof. Laila and also Michelle, maybe can you help us to educate, how do we educate the public? Because you know, this is like, this treatment is very viral, okay, and unregulated. So sometimes when they ask us, should we go for this? So what will be your reply to the public?
Right, thank you, Prof. Sharul, for the question. Now, I've been asked by newspapers, reporters about this question because apparently there's a lot of black market, people getting it from here and there, GLP-1 receptor agonist. An aesthetic clinic is selling like nobody's business, and they sell, the way they sell it is patient come for injection and they pay per injection, and the price is much higher. Well, you talk about diabetes and obesity management, the core management, if you look at the CPG and if you look at any other guideline, the lifestyle intervention has to be there. Failing lifestyle intervention, then you add pharmacotherapy, and after that maybe surgical therapy for obesity. And while you promote or you advocate pharmacotherapy as well as surgical therapy, you cannot forego your lifestyle intervention. And a lot of time, those who actually buy the medication outside viral because they look at TikTok. I know GP are actually promoting it, certain clinics in TikTok, in other social media. They actually, how do I say, they promote it and they don't assess the patient properly. The patient need to be assessed for the comorbidities and whether the patient will actually respond just by taking medication alone. Studies have shown in SURMOUNT studies using tirzepatide, in STEP study using semaglutide, that the reduction of weight loss is more if you apply lifestyle intervention, meaning calorie restriction together with exercise and physical therapy. Then if you pay so much for this expensive medication, you want to see more, a better results rather than 15% reduction. You may want 30% reduction, isn't it? So you have to also advocate lifestyle intervention. And of course, the side effects. And people don't mention about, if you just simply buy, they don't actually know whether do they have family history of thyroid cancer and so on. So in initial trial, in animal study, they have shown that there's increased risk of medullary thyroid cancer as well, and that's what people don't know. So, so we are actually telling the pharmaceutical company that you please don't do this and, promoting it just because you want business. And apparently the GPs and the aesthetic clinic, they're actually getting it not via the normal pharmaceutical company. Maybe Michelle want to add on.
Yes, please.
Thanks, Prof. Sharo. Very interesting question. I'm not as famous as Prof. Laila. I don't get interviewed by newspaper, but I get interviewed by family members and friends a lot about this. Why I normally ask them, why do you want to use this drug? So a lot of them behind the scene, they'll say, I want to be healthier. But after you talk, it's basically the truth comes out. The truth is, I want a quick fix lah, actually, because tired really, I tried so many things. So I also let them know, when you want to try this drug, it has to be, if you notice the drug is not sold or licensed or studied as a weight loss medication, it is studied and indicated as an adjunct. Adjunct means it's an add-on, it's not the main therapy. The main therapy is lifestyle and diet modification. So in order to, like Prof. Laila said, it's expensive. So a lot of our friends and family, because they are given by the GP, it's sold to by the GP, they start ready, after a few months, they see the effect. After a while, they're off. So many cases rebound because you did not follow the instruction, you did not comply to the proper weight and diet management, it will rebound. So because the drug is costly, you cannot continue, right? So a lot of patients will end up stopping, rebound. So I scare them with this. After I scare them with this, then they will think twice to find ways to, because now there are many types of diets, right? There's, they can explore the other things, and there are proper dietitians to help with this. So I normally encourage them with that first and remind them that this is an add-on. It should not be the main therapy. Yeah.
Okay, thank you. So basically, because all of you medical students will be the frontliners, right? So you will be facing the same question. So I think the take-home message is you need to emphasize to the patients that the lifestyle modification, exercise, diet is the most important thing, because maybe Prof. Dato would like to also comment, because I saw in his TikTok, actually he made an effort to wake up early and do exercise, So when I saw the TikTok, I was also inspired. So now I make it a point, every morning I have to exercise for at least 15 minutes. Maybe Prof. Dato can comment?
Thank you, Prof. Sharul. So basically, I think I don't want to, lengthen my talk. Basically, everything has been covered by Prof. Norlaila and for Michelle. But basically, I prescribe quite a number of GLP-1s and GLP-1 GIPs. But the most important thing is, there's nothing wrong with prescribing it as long as you prescribe to the right patient. So patient selection is important. And in my repertoire of treatment option, which I tell my patient, is a bit more wider than endocrinologist, because it involves not only pharmaco treatment, but also endoscopic procedure like intragastric balloon, the swallowable balloon. We also do here endoscopic sleeve gastroplasty. That means using endoscopy and stitch the inner lining of the stomach and make it small, and ultimately bariatric surgery proper. But a lot of people sort of like tease me that the number of your procedure will come down drastically because of the advent of these medication, which I cannot dismiss. It's really good. And I do see patients on GLP-1s or the dual combination within 2 doses of Mounjaro, like 2.5 and 5, they lose about 10 to 14 kilos. Very impressive. And but what differs from the others that only lose half of it is they really change their lifestyle. And they felt that I've spent a lot of money. It's very expensive. I have to say that those who can afford are only privileged population. I think only 20% of Malaysian population that can afford all these medication. Because one is the initiation dose. Number 2 is to sustain it. And this is why the good thing about having this medication now, it gives us as a bariatric surgeon the opportunity to become a bit more selective in choosing who should go for bariatric surgery, who should go for endoscopic procedure, who should go for balloon, and ultimately who should go for pharmacotreatment. And for me, definitely the best way is, having failed lifestyle change. And this is one of the main criteria for a Medicare, which is the national insurance which actually endorsed the treatment of obesity in America. Having failed lifestyle change and you have attempted rigorously to lose weight within 6 months, then you can proceed to the next level of treatment. But the compartmentalization of treatment is now beginning to become more obvious with the advent of pharmacotreatment. Because, I have to say, in the past, it's ridiculous. Patient with BMI 27, some surgeon operate. It's just absolutely no-brainer. Nowadays, I wouldn't talk about surgery unless the BMI more than 37.5, because these drugs are really good. But the most important thing to emphasize is the safest to get these drugs is from the hospital. Number two, the other problem with all these beauty clinics is they need a lot of capital to store and buy higher dose. And you cannot just prescribe patient 2.5 and 5 milligrams. And then how they dictate that is they make sure that the patient comes back every week to have the injection. And you can see a lot of patients that come and see me has been on 5 milligrams of Mounjaro, for example, or Wegovy of 1 milligram. It's not even Wegovy. Wegovy is 1.7 and 2.4 by right. So they just keep holding the patient. And then, of course, the patient just sustained the weight loss and they only lost like 5 to 10 kilos, where they have potential to lose more. And the most important thing is for the prescribers, it's essential that they need to make sure that what I normally do is explain how it works, who are the people that requires these medication, what are the side effects, and I always make sure that I screen them, make sure there's any family history or them, any history of thyroid cancer, but not only thyroid cancer, medullary thyroid cancer, and patient has history of MENS. 2, multiple endocrine neoplasia. And number 2 is any history of pancreatitis or pancreatic cancer. Even though if you look at the risk of pancreatitis is less than 1%, and by right, you don't really need to emphasize and explain to the patient because it's very low. But nevertheless, without making everyone be too alarmed, is a really good drug. And if you look at statistic, for every 10 patients, 9 benefit, only less than 1 would probably get unusual adverse effect. And I still suspect there are so many confounders, especially when you're obese, which contribute to acute pancreatitis, whether it's direct or indirect effect. But I think if you get one, most likely it's more of an idiosyncratic effect. Hence, you are a bit unlucky.
Okay. Thank you so much, Prof, for the questions and for the answers and explanation. So I think we are towards the end of the session today. And before we go, we would like to share a few questions regarding our session today. So I think can share the Kahoot question from there.